Hi, ma'am. Good afternoon. Am I audible? Good afternoon, ma'am. Hello.
Yeah, good afternoon. Am I audible, Dr. Valan?
Am I audible?
Yes, you are. Hello, can you hear me?
Yes, I can hear you, and my voice is clear.
Okay, I made you co-host. So just see.
Yeah, because like somebody is not allowing me. Yeah,
Your voice is cracking, Dr.
I
Valan.
think it should be okay, and voice is cracking. I have full tower. Internet connection is unstable. Okay, so I'll connect through LAN. Okay,
Okay.
that's the best way. I'll do that. Just wait for a minute.
All right.
Hello, it is clear now. No, not cracking, right?
Yes, it's clear now. Absolutely clear.
Okay, fine.
You are
So
co-host. Now if you want, you can try
let
share.
me share my PPT and see
Yes.
also. You need a BIOS or something? Just in case I'm just WhatsApping you. If you want to introduce, you know, but still,
Please.
I am sending you in WhatsApp.
Okay.
Done. Okay. Just let us keep it very simple. So the slides has to be visible. So full
Yes, they are
screen.
visible. Yes, they are visible.
Okay.
All right. And this is live on YouTube also. So
Oh,
anybody,
really?
yes, we have our own YouTube channel, IAMM PG Masterclass. So we've gone live on that. And it's also getting recorded. So we upload usually the recorded class on our YouTube channel where people can see it because the students might like to see something later on, and these are all exam oriented topics. And we are just waiting for Dr. Aarti to join. The moment she joins, we'll begin.
Sonal ma'am, Artip Kapil ma'am is now head in which institution in Delhi? After AIMS?
She's in Hindu Rao.
Oh, okay.
She's the president of our association as well as the Delhi division. Actually, I don't know. Ma'am says she has joined, but I can't see her here.
You are IAMM executive member, right, ma'am? Your current position?
I'm secretary IAMM.
Secretary. Okay. Okay.
Just waiting for ma'am so that we can begin now. Aarti ma'am, have you joined? So,
हेलो
हाँ मैम, we can hear
हाँ
you.
जी सॉरी अच्छा अभी मैं वीडियो ऑन कर देती हूँ
Okay.
हाँ ओके
Yes, sir.
एक मिनट में इसको ठीक कर लेती हूँ आज ना एक्चुअली नैम्स में भी कुछ चल रहा था तो मैं बस अभी निकल गई अब मैं एक बार वो बोलना भी है ना मुझे
हाँ मैम, you are already live.
ओके ओके
Okay.
सो शुड आई वेलकम डॉक्टर क्या आप बोलोगे
मैं बस स्टार्ट करती हूँ. So yeah, good afternoon everybody. So for this very interesting non-microbiological but most important for microbiology outbreak investigation, we have a very quite an expert in this field, and I will now request our president, Dr. Aarti Kapil ma'am, to please introduce the speaker for today, and then we can begin the proceedings. Over to you, ma'am.
Thank you, Dr. Sonal. And on behalf of IAMM, I welcome you all for today's webinar. And I would like to introduce our speaker who, many of us know. He is working as a public health specialist for the Division of Healthcare Quality Promotion at the CDC, India Country Office. I'm sure you would have interacted with him. He supports infectious diseases surveillance with focus on activities improving prevention, detection, and response to antimicrobial resistance and surveillance of healthcare associated infections in India. So, today he is going to talk to us about outbreak investigations, which you understand, especially related to the healthcare associated infections. And I think for our PGs, it is very important to understand how, because you are going to experience such outbreaks from time to time, and there will be challenges to establish whether it's a real outbreak or it's a pseudo outbreak. So request Dr. Wallen, please, without wasting much time, to please join us and enlighten us with his experience and his talk. Dr. Wallen, please.
Thank you so much, ma'am. I have some problem in connecting my camera. Sorry for that, but I'm projecting my slides. First of all, I would like to thank IAMM President ma'am and Secretary ma'am Sonal ma'am for inviting me to provide this talk, which is very, very important for any public health person, which includes the microbiologist. I hope my slides are visible. Am I correct?
Yes, Dr. Wallen, they're
Yeah.
visible.
Okay. So no country or health system, however sophisticated, can claim to be free of healthcare associated infection. If somebody claims we don't have any healthcare associated infection in our hospital, that might be, you have to really look into it, because like it is impossible. So and this has been reiterated in the global IPC report of 2022, which was released by World Health Organization. So in the same report, they also mentions out of every 100 patients admitted in any acute care hospitals across the high income countries, 7 will get a healthcare associated infection. If 100 patients are admitted, like we can expect 7 people getting a healthcare associated infection. And you know very well, healthcare associated infections are infections which are not present or not incubating during the time of admission, and the hospital might be the reason for that particular infection. And these rates are even almost like more than double in low and middle income countries. So that is like 15 patients, those who are admitted, like out of 100 in any low and middle income countries, will acquire at least one healthcare associated infection during the hospital stay. So healthcare associated infection transmission of SARS-CoV-2 has been a major issue throughout the COVID-19 pandemic, which is still ongoing. And especially during the first wave and second wave, we have seen a lot of transmission which happened inside the health facility. Patients getting affected from patients getting affected from the care providers, patients getting affected from the doctors getting affected from the patients, and laboratory personnel getting affected from people, those who are coming and giving. It was really a major challenge like we have faced and come across like during the first and second wave of COVID, and like still like it might be getting transmitted now also. Among the hospitalized patients with confirmed COVID-19, up to 45% were infected with the healthcare setting. That's what the global IPC report says. So like 45% of the infections like of COVID like happened in a healthcare setting. HAI has a major public health challenge in India also. And the clinical microbiologists play a key role in detection of HAIs and outbreak response. The healthcare associated infection outbreaks remain a major deterrent to patient care and patient safety in both public and private sector, can have massive financial and public relation impacts on healthcare facilities. And these are reported often, but not often systematically investigated. So whenever there is an outbreak getting reported, like people, either don't want to take things forward, or they will be sporadically doing like some sample collection, some environmental sampling. And most of the time, systematic investigation of a HEI doesn't happen as it happens in a community outbreak. And also there is one more challenge, till recently we never had any guidelines also regarding the healthcare associated outbreak detection and response. So in 2020, Ministry of Health and Family Welfare through NCDC has brought in national IPC guideline for healthcare facilities, where there is a separate chapter on healthcare associated infections and a sub chapter on healthcare associated outbreak. But there are no clear policies regarding healthcare associated outbreak detection and response in our country, not only in our country, in many countries. So now we are talking about outbreak. Like, what do you understand by outbreak? So can I request like people to chat in the chat box, so that let us make it a little bit interactive. Like, as far as the microbiologists, those who are participating today in this PG Masterclass, like, what do you understand by an outbreak? What is an outbreak? Can I request the participants to type in? No one is typing in. Okay, I'm getting some. Okay. Okay. So Tanvi has mentioned like increase in number of cases more than expected number in a defined time. Very good. So more than expected as per the local scenario, increase incidence about normal for the disease. So let us see the definition of an outbreak here. The occurrence of more number of cases, as you have rightly pointed out, than expected for a particular place in a particular time. So it might be, the place might be an ICU, the place might be a ward, the place might be a hospital, a place might be a district, a place might be a country, right? So based on like what disease you are dealing with, so that defines an outbreak. So you have to have a person, place, and time. Increase in number of people getting the disease, increase in a particular place in a particular time. So that is what is known as an outbreak. So now we have often encountered this terminology, like when we are working in microbiology laboratory, clusters, right? So sometimes small outbreaks are referred to as clusters by many. Functionally, there is no difference since they are both problems and both need to be investigated and controlled. So identifying and potential outbreak. So usually, how will you identify an outbreak? Usually it is through a review of surveillance data. So for reviewing the surveillance data, very important thing is you should have surveillance systems in place. So unless you have, whether it is the community outbreak or a hospital onset outbreak, unless you have a surveillance data, you cannot tell, whether it is an increase or decrease, right? Or whether it is the same. As compared to last year. If you want to tell it is more than last year or more than last month or more than 5 years before, then you should have a surveillance data available. That's very, very important for every health facility and like all the microbiologists, those who are participating today. So you should have surveillance systems available for healthcare associated infection. Then only you can tell this is an healthcare associated outbreak or not. And also potential outbreaks can be detected through clinical reports of unusual diagnosis. So it depends upon like what disease you are dealing with. Like sometimes even one case might be a trigger for an outbreak investigation, so that like that we might not have encountered the disease in many humans. So we may have to prevent that infection from getting transmitted. So it depends upon which pathogen or which disease you are dealing with. Like sometimes it can be triggered from the clinical reports of unusual diagnosis. Most of the community outbreaks get triggered from the public, like the public reports first, like, there is a increased number of diarrhea cases or increased fever cases happening in a particular village or something. So you can also get outbreaks identified from the public. And many a times the media also plays a very crucial role, right? Like when there is increase in number of cases, before it comes to the come to limelight to the public or to the to the health authorities, the media flashes news, there are people suffering and getting admitted, like a group of people are continuously getting admitted from this particular village or a particular district. All those informations like we have seen. So identifying a potential outbreak, it could be from the surveillance system data. If it is available, this is the best thing can happen. It can happen also from the clinical reports of unusual diagnosis, reports from the public, and reports from the media. So let us see an example of an outbreak which happened and I'll show you, like, this is a real outbreak which happened, which was investigated by All India Institute of Medical Sciences, New Delhi. So this outbreak, for example, just to make you understand, in 2018, a medical microbiologist working in a mid-sized teaching hospital, while reviewing the monthly data, noticed there is a cluster of 21 cases with Burkholderia cephalaceae complex infections. And all infections occurred in 16-bed surgical intensive care unit. And all of the isolates were highly resistant and had the same phenotypic resistant pattern. And as microbiologists, Burkholderia cephalaceae is one of the environmental pathogens, like, which is highly resistant to most of the gram negative, the antibiotics which works against the non-fermenting gram negative bacteria. If you see CLSA 2023 here, if you see Burkholderia cephalaceae complex, it is resistant to ampicillin, amoxicillin, it is resistant to piperacillin, ticarcillin. Like, most of the antibiotics are already intrinsically resistant to Burkholderia cephalaceae. So now the challenge is, when a multi-drug resistant pathogen, unusual pathogen is getting spreading, and it is causing the bloodstream infections, then you have to immediately respond and contain, right? So this is like, and also the treatment strategies will be much more different. Like, your usual antibiotics, what you are going to prescribe doesn't work. Like, your etapinam doesn't work. Your colistin, if you are using colistin as a last resort because it is a referral hospital, colistin doesn't work. Polymyxin doesn't work. So most of the drugs are not working. So your treatment strategy also varies. So this outbreak is typically a healthcare associated outbreak which happened in an ICU. There was an increase in number of cases as compared to last year, and it also warrants immediate action for appropriate treatment, treatment and management of these cases. So why investigate a HAI outbreak? So mainly to identify the cause of the outbreak, to control the outbreak, to prevent similar outbreaks in the future, provide new research and insight, evaluate existing prevention strategies, and to address public concerns. So should you investigate depend on severity of illness, potential for spread of this infection, political consideration many of the times, public relations, resource availability, and availability of prevention control measures. So there is no point in investigating an outbreak when you don't have available preventive and control measures. So that, like, you cannot act upon it. Like, there is no point in investigating an outbreak. So if you investigate an outbreak, mainly you are investigating it for really containing that, controlling that, and preventing further outbreak. That should be your focus. So coming to Burkholderia cephalaceae, we have already discussed, like, it's an important cause of mortality and morbidity in hospitalized patients because of high intrinsic resistance. Because by the time you find out the pathogen and you start treating, if it is a bloodstream infection, like, they could have progressed, very badly with the disease, right? Like with the sepsis with Burkholderia cephalaceae or something. And that is even worse in patients having some lung disease and things like that. So they are potential to grow in hospital surroundings, like taps, sinks, irrigation solutions, IV fluids, antibiotics, and antiseptic solutions, and needs to be correctly identified. And all the most important thing of this Burkholderia cephalaceae is they will present in biofilms, and it is very difficult to eradicate them when they form biofilms in water pipes and things like that. Coming to this conducting the outbreak, there are 10 steps involved in investigating an outbreak investigation. So the first and the most important step is, first you have to verify the diagnosis and confirm this is an outbreak. How will you confirm an outbreak? For confirming an outbreak, you need a baseline data available. And based on that, you will confirm whether there is an increase in number of cases or not. And you will verify the diagnosis and confirm it, like, okay, this disease is happening and this is an outbreak. Second step is informing key stakeholders about the investigation. Third step, constructing a clear case definition so that, like, you know what to measure. Fourth step is identifying cases and data collection based on the constructed case definition. Fifth step is examining descriptive epidemiological features. Sixth step is observing and reviewing patient care. Seventh is generate hypothesis and test hypothesis. Eighth, collecting and testing environmental samples. Ninth, implementing control and prevention measures. And 10th step is following and communicating the results to the key stakeholders. That includes the patients. So now let us see step by step, like about like each. Let us see about each steps, like how we do. So one thing you should remember while conducting an outbreak investigation, I have shown you all this very beautiful 10 step. So while you are doing a real-time outbreak investigation in your healthcare facility, multiple steps can happen simultaneously, and steps are often repeated several times. Like, for example, you develop a case definition, you may have to revise the case definition when you find out something new. Earlier only the pathogen was available, now you have the AST results after 2 days, so then you may have to review your case definitions to include the phenotypic resistant pattern, so that, like, where the clustering of cases are happening or something. And many a times, you may have to repeat, and you will identify an outbreak. Yes, that is the first step, and you will verify and confirm it, but simultaneously you will also be doing the prevention and control measures. So as I had shown you earlier, sorry, yeah. So if you see here, the first step is verifying and diagnosis. The ninth step is implementing control measures. But both of them, once you identify, you will immediately implement general infection prevention control measures. You will do IPC evaluations so that to make your system strong. So you have to understand multiple steps can happen simultaneously, and many a times you may have to repeat the steps based on the evolving evidences from your outbreak investigation. So before you begin any outbreak, you have to tell to the lab. You are microbiologists, you know very well, but you have to tell your head of the department and your HICC that, okay, we have a report of potential outbreak of X and Y Z pathogens. Now we have to save all the isolates. Please make space for saving the isolates. You need to have all the laboratory reagents. You should establish the linkage and referral with the reference lab. If you cannot test, maybe some advanced testing methodologies are not there for confirming the particular pathogen or a AST profile, then you may have to order for additional tests. So inform the reference laboratory also for transporting the samples. This is very, very important, because the confirmation of the outbreak, the confirmed case definition will come only from the laboratory confirmed cases. So this step is like very, very important. Before starting, educate the lab about this outbreak, what is happening, and all the laboratories should be aware of preparing your laboratory for receiving more samples, having adequate reagents and consumables available, and also space in your storage for archiving all the isolates, like what you isolate from this outbreak. And you have to give instructions to your lab technicians regarding archiving of all these isolates. Like maybe later you may have to do any genotypic linkage or something like that. So then you will be needing all these isolates later. So now coming to an important process regarding your outbreak investigation. So literature review. So there are a lot of published outbreak investigations. More than 50,000 papers are available in a database. You will get good leads both on where and how to start your outbreak investigation in your facility, because most of the outbreaks, like in various part of the country, in our country also, like many outbreaks have been conducted and documented and published, and these are available as a resource in this particular website. I'll be sharing you the slides, and I was told by Sonal ma'am that like she will be also putting this in YouTube, so you can visit that website. Like this website view has changed, like but the website remains the same. So you can go to this website and you can check here. So there are a lot of published literature. So you just search for your particular outbreak or particular pathogen, then it will list out all the outbreaks related to that particular pathogen. Then you can read those articles, and then you can know where to start, how they did it, and how you can fine tune your outbreak investigation steps. So coming to the first step, verifying the diagnosis. So you can, for verifying the diagnosis, you have to evaluate the clues like signs and symptoms, laboratory findings, duration of symptoms, like how long they are having the symptoms, suspected exposures, suspected viruses, bacteria, or toxin, and hospital onset, because we are dealing with a healthcare associated outbreak. So laboratory confirmation is the most definitive method for verifying the diagnosis. This may help define the incubation period. one important point you have to keep in mind, you have to interpret the negative results with caution. The reason being, the organism may not have been tested actually, and specimen collected might be too late in the illness. Like for example, like for an ICU patient, you're taking a specimen. So before you take the specimen, he would have been already given multiple, intravenous antibiotics. That might be the reason the pathogen is not getting tested. So the time you took the specimen might be delayed, so you may not, like, that pathogen is not there doesn't mean the illness was not present. So this is, you have to keep this in mind whenever you are having a healthcare associated infection, and also mishandling of specimens. So if there is a transportation delay, or you didn't store it properly before it reached the lab and got processed, so that also will reduce the yield of the growth of the pathogen, and you may not be able to isolate that particular pathogen you are dealing with. So maybe when you have 10 cases, because of all these factors, 5 cases you might get isolated, and remaining 5 cases you may not get. So you have to be careful that there might be all these fallacies, like, which can happen in any healthcare associated outbreak in real time. So you look for an increase in case reports of that particular pathogen, and review the reports and data, confirm that cases are having the same disease, and confirm that the number of cases exceeds the normal. So normal means you will be already having a baseline for different diseases. So sometimes it might be completely new disease. Like for example, like, for this particular example where we saw about Burkholderia cephacea. So it was never reported by that particular lab, then suddenly they start getting reporting this environmental pathogen. So then that might be also a possibility, but many a times there might be sporadic reports of some pathogens, but again there is a sudden spurt of increase in number of cases from a particular ward with particular phenotypic resistant profile. So that triggers your outbreak investigation. And you should also confirm the healthcare onset. Healthcare onset is nothing but more than 2 days of admission, like what we usually call the infections which are never present, like during the hospitalization, or incubating during the admission period. So now coming to an important point, like, Dr. Aarti Kapil also mentioned about outbreak versus pseudo outbreak. So many a times when you start investigating an outbreak, like just following the principle of increase in number of cases which are clinically relevant from the clinical relevant cultures, you might also stumble upon the pseudo outbreaks. So pseudo outbreaks are nothing but increase in report of positive cultures without evidence of a disease. So it may be due to a surveillance artifact. So you might have introduced a new definition for that particular disease, or you might have had a new physician who might be classifying that particular disease, or you might have introduced a new methodology. Like for example, earlier you never had a automated identification system. You were doing everything manually, and like, you were not very resourceful in having all the reagents for identifying all the lactose fermenters, non-fermenters, for example. Okay, so now what happens? You introduced a new automated system into your health facility. Now it start giving all the species of non-fermenters, and you started getting increase in number of Sternotrophomonas or Ralstonia picketi. So now this is not an outbreak, because you never had that luxury of detecting this particular pathogen. You never had the reagent for doing conventional method for speciating all this non-fermenting bacteria. But suddenly you introduce an automated system, then that, because of the automated system, there is an increase in number of cases getting reported from a particular place, from a particular during a particular period. So this is what is called pseudo outbreak. So that pseudo outbreaks either can happen due to introduction of new definitions or introduction of new surveillance systems also. For example, you never had a system for surveillance of bloodstream infections or CLAPSIs. So now you collaborated with the network of hospitals, and you started, understanding the definitions, and started introducing HAI surveillance in your health facility. Now you will start getting increase in number of CLAPSIs. That doesn't mean, because you never reported earlier, that doesn't mean that you never measured CLAPSIs earlier, right? That's why you never got any CLAPSI cases. So introduction of any new definitions or surveillance system into your routine work might also trigger thing, like, trigger your sense might be, you might think it might be an outbreak, but you really logically think, then you will understand this is due to introduction of the surveillance system or introduction of a new definition in your routine clinical care and not actually an outbreak. So this is what we call as pseudo outbreak. Coming to the next step, informing the key stakeholders about the investigation. This is a very, very important step. Once you get reported about an outbreak to your laboratory, or your laboratory thinks it is a potential outbreak, the first thing you have to do is please go and report your head of the department, and please report your administration about, like, this is what we are seeing. We are seeing an increased number of cases from this particular ward of particular pathogen. We have verified and found out this is not a pseudo outbreak. We because there is no artifacts in our surveillance data. So this is a real outbreak. Now, please guide us what to do. Your administration has to be informed about this outbreak, what you are getting to know, and your infection prevention and control committee has to know that an outbreak investigation is happening. So as per the national IPC guideline for healthcare facilities, the secretary of the infection control committee in every hospital is a clinical microbiologist from the microbiology department. So it might be head of the department or any other associate or assistant professor working there. So please inform them about the outbreak happening. And also, as per the national IPC guideline, it is a mandate that every hospital should have a response team for outbreak also, like an RRT. And we have seen during COVID, there were emergency response teams in every hospital, which decides lot of things for preventing transmission inside the health facility. Like that, we should be prepared for any outbreak which might happen, which could happen in a healthcare facility. So you have to inform your hospital infection control committee, your hospital administration, your infection control staff about this outbreak. You have to inform your laboratory staff, as we had already mentioned, about saving all the isolates, archiving them for further testing and things like that, and be prepared for receiving increased number of samples and things like that. You have to report to your local health authority through your superintendent. You don't have to do it directly. You inform your superintendent, and if it is relevant, or if it is a relevant public health threat, so he will be informing it to the district or state public health authorities or a national public health authority based on which disease you are dealing with. If it is a reportable or a notifiable disease, it will be notified to National Centers for Disease Control for a national level response action. Based on the pathogen you are dealing with, your superintendent will decide how and whom to report to. But when you come to know about an outbreak happening in your health facility, please inform your hospital administration, your infection control committee, and your lab. And they will in turn inform the local health authorities if there is a need. So there are few constraints for outbreak investigations. Like many a times we encounter practically, and I have also encountered, there is always an urgency to find out the source and prevent cases. And there is also a pressure for rapid conclusion. What are you doing? Didn't you find anything? Just close this and give a report. And many a times, limited human and environmental samples for testing is available for us. So many a times, we don't have time for doing analytical studies, and because you don't have a statistical power for that particular, because you have very less number of cases. There might be media reports which will be giving biased interviews, when they come to know. Usually healthcare associated infections not get flagged very often by the media, but sometimes they will do their own postmortem and they will give their views. So that also might influence your outbreak investigation to a negative side. And there are always pressures because of legal liability when it comes to limelight. So these all are the constraints of doing an outbreak investigation. Coming to the next step of constructing a case definition for any outbreak investigation, whether it is a community onset or a hospital onset or a healthcare associated infection outbreak, constructing a case definition is the very, very, very important step. And the elements of the case definition should include your clinical criteria, signs and symptoms, person, place and time criteria, because who's getting infected, where they got infected, which time period they are getting infected will provide you lot of clues. When you know person, place, and time in epidemiology, you will you will be able to think in a more focused way, and you will reach the conclusion. It will guide you to get the source and things like that, like very easily. And you should have the laboratory test, like as far as HAI outbreak is concerned, like included in the case definition. And you should have to decide, how narrow your case definition should be and how broad your case definition should be. If you make it very broader, it will be very sensitive and you will be having n number of cases. If you make very narrow case definition, like very focused case definition, then many a times, you might miss out real cases. For example, you are keeping a laboratory test and only the positive isolates, like you will be including, means there might be a lot of fallacies which might have happened because of poor laboratory pre-analytical phase errors. So that might lead to you not including actually a case of that particular outbreak because like you didn't get a positive culture from that particular patient. So you have to be very careful, like when you are framing case definitions, and you have to strike a balance. It should be sensitive, also it should be little bit specific, so that always you try to have a sensitive case definition to include more cases, so that like later you can fine tune the case definition and you can narrow down when you have more information available. So case definitions may vary based on the settings, based on the etiologic agents. If known, include in case definition when you have a healthcare associated outbreak. It allows study of either both infected and colonized patients, and specificity of the definition to suit the cluster or the outbreak has to be considered. Based on signs and symptoms of infection allows investigation of an outbreak caused by numerous organisms. So it will be very, very sensitive, and definition may change as investigation proceeds. So when you have a case definition, usually there are, we use like 3 case definitions in any outbreak, whether it is a community or a hospital outbreak. So that includes a suspected case, a probable case, and a confirmed case. A suspected case is nothing but a person with compatible symptoms with possible epidemiological link. There might be an epidemiological link or there might not be an epidemiological link. A probable case is a case with clinical symptom more specific with a typical epi-link available for that particular disease. And a confirmed case is a probable case with a laboratory confirmation. You have isolated a particular pathogen. In that case, then it will be called as a confirmed case. So usually, like this is the dictum we follow. Either it is whether you are dealing with a community onset outbreak or a hospital onset outbreak. So you have a suspected case, probable case, and confirmed case. The next step in investigation of an outbreak is identifying cases and data collection. So once you have a clear case definition, then based on that case definition, you will find like who all are fitting into this case definition. And then you will start collecting the data on like the person's getting all this like, symptoms and things like that. So many outbreaks first recognized by the healthcare personnel in healthcare associated outbreaks. Active case finding requires casting a wide net at the beginning of the investigation, and it helps provide more information about the outbreak and define the exposed population. So how do you find cases? So there might be various sources to find cases. So it can be your microbiology registers, which is available in your laboratory. Sorry, lost connection a bit. So it might be from your infection control or surveillance records. You can discuss with your clinicians and they will tell like, these all are the patients who had symptoms. You can get details about the cases from the clinicians, and then you can go back and see their case records. You can get from operation notes if it is a surgical site infection. So you can go through the operative notes and then you can see like there might be something happening during infusion of a particular antibiotic or like particular IV fluid during the surgery, like operation notes and things like that would be helpful. Pathology reports, pharmacy records, radiology reports, central service supply records, because like there might be increased use of particular thing, or there might be a particular supply which might have caused the outbreak. It was having an infective source, so that might have that might be the reason for transmission of this outbreak to many patients. So you can see this, like based on which outbreak you are dealing with, these all will be helpful. And also the logbooks from the nurses and purchasing records, like these all are the sources which will help you to find more cases in your outbreak investigation. So case finding challenges. Finding cases when you can't rely on microbiology is very tough and requires a lot more effort in chart review, because we know very well that reviewing the case records, it takes a lot of time for any investigators who's investigating an outbreak. If you have a laboratory record, like you can directly, and you know the pathogen already, so just go to that particular case and you can pull down that case sheet and you can get all those information. But when you don't have that, going through all the case sheets and finding typical symptoms and things like that, it will be very, very challenging. And many a times what happens also, you have to be prepared. The case sheets might have been submitted already to the MRD department, and they will be providing you very limited number of case sheets per day. So that also will slow down your outbreak investigation. So these all are the challenges, like you might encounter while you are dealing with an outbreak investigation in a healthcare facility. But again, you have to see how hard should you look. Remember, the goal of the outbreak investigation is to stop the outbreak, but not necessarily to uncover every case. If you are able to get enough information, that is more than enough. If you can start your control measures, and you can focus on infection prevention control activities. More exhaustive case findings efforts may not be needed upfront, but might become important if you can't get things under your control. So you have to strike a balance and decide how far you should look for getting all the cases into the outbreak investigation when you are dealing with a healthcare associated outbreak. If you are able to figure out like reasonable number of cases, and you are able to get some conclusive information regarding the source or preventive measures, so that is more than enough for a healthcare associated outbreak investigation. So coming to the data collection, so identifying information, demographic facts, clinical information, risk factor information are very, very important. So all identifying information, what you get from these patients, because demography details are confidential information, and also clinical informations are confidential information, and you have to maintain utmost confidentiality. Always try to code the patient names and things like that, encrypt the names, and then you manage a list. You might have the patient original name, but whenever you are presenting or whenever you are communicating to others who are not relevant for your outbreak investigation, so try to encrypt the individual identifiers of patients, or physicians or something like that. Just you can encode them, and then after encryption, you can do that. So because you have to maintain utmost confidentiality. So the question is may include the potential risk factors or exposures in healthcare associated infections. That could be medications, procedures, date of admission and discharge, which will give you very important information. Consultants, facility locations or units, healthcare providers, host factors like age, gender, and immunity. These all could be included in your data collection formats. And there are already existing data collection forms. There is an updated form also. I have provided the link for the data collection form for a healthcare associated outbreak. It is in the Word format from CDC. So you can always download this from the CDC website mentioned here, and you can modify it based on your need, based on the exposures, based on the pathogen you are dealing with, all those things. So these forms will be very, very helpful for you to collect data. So in this form, this template has collecting history about various illnesses, collecting history about various devices, which will give you a lot of clue, based on which outbreak you are dealing with. You can modify the data collection form, which you can download from the CDC website. The next step in outbreak investigation is examining descriptive epidemiological features of cases. So once you have collected the data, you will do the descriptive epidemiology. So you will try to find who is at risk. So then you will describe the data by the person, place, and time, who is getting infected, where they got infected, and which time they got infected. So this will give you a clue about the incubation period and things like that. So also, like this characterizes the outbreak, identifies the population at risk, provides clue about the agent, source, or mode of transmission, provides information to begin control measures, and familiarize the investigator with the data, like what you have collected. So options for describing the data using descriptive epidemiological analysis is, first is line listing. You will create a simple Excel sheet can be enough. So you will put all the fields as columns, and each patient will be, each case will be a row in that particular line list. So you will be collecting, as we had already mentioned, demographic, clinical, and exposure information. You can present your data as graphs or histograms, like bar charts and things like that. So for location type, you will be presenting it as a spot map. So let us see how it looks like. A line list which is created from case data. Each row is a case and each column is a variable of interest. It could be signs and symptoms, onset date, to understand whether this is an outbreak or not. Medications, intravenous solutions, etc. can be added there. Antibiotics can be added there, a particular antibiotic which you are suspecting. Invasive procedures like surgeries, if you are dealing with a surgical site infection outbreak. Consultants, staff contacts, host factors, and lab results. Like these all are some of the examples of variables which you could be including in your outbreak investigation line list. The most important part of the investigation, since it derives all the investigation efforts to get a conclusive evidence for your descriptive epidemiology. Here, what I have shown is a ICU room layout and how the cases are getting detected. So this is what we call a spot map. So in hospital, the numbers and case patients and locations have been mentioned in this. So you can just with a paper and pen, like you can just draw where these cases are coming from. Is it towards one particular corner of that particular ward or something like that, or maybe the cases near to some facility like medication trolley or something like that. So all those information will be provided if you have a it will be generated, like if you have a spot map like this drawn regarding the place of your outbreak which is happening. Coming to the next thing is describing the data using an epi curve using bar charts. An epidemic curve is a graphical display of a number of incident cases in an outbreak plotted over time. The y-axis shows the number of cases of illness. The x-axis shows the date or time of illness onset. The unit of time often based on the incubation period, that. And it provides an important information regarding the magnitude of the outbreak. To show the time trends of the outbreak could help to determine the incubation period and show pattern of spread and highlight the outliers. So let us see some examples of epidemic curve. So the first curve here is a typical single point source outbreak. So the slowly the cases started rising. It reached a peak and something has happened. It might be an intervention or maybe due to some other factors, the slowly it comes down and there will be nil cases. So if you see here, the x-axis you have the days and the y-axis has the number of cases. So this is a typical single point source outbreak. If you see here, the next bar chart which I am showing, there is a common continuous source which is continued to happen. Cases started, but it is continuing to rise and it is not coming down. So it's called a common continuous source outbreak. And this is a epidemic curve which shows there is an intermittent source of infection. So the source is there, then you do something, the source goes away, then again, this is what happens in most of the healthcare associated infections. So there is a source which triggers an outbreak, it goes away, then again you started getting the same phenotypic resistant pattern of a particular healthcare associated pathogen. So again, it goes away, you do some environmental cleaning or something like that, you goes away. So unless you remove the source from this outbreak, this is going to come again and again. And these are one of the most commonly seen scenario in many of the hospitals. And unless you remove the source, this is going to continue like this for years together. So the outliers, like this is very, very important, like when you are constructing a case definition and a line list and your epidemic curve and all. An early case or a late case might be an outlier, because like that might be independent of like what you are dealing with in the current outbreak. This may represent an unrelated incident worth examining carefully. It might be related, maybe there might be some continuity, like you might be missing the cases in between. That might be a possibility and may point directly to the source. So the first case, the primary case, might be pointing you like what happened to that particular first individual. This usually typically happens, in infections which are having long incubation periods and things like that. The first case might have happened long back, then lost touch, then the case might be spreading the infection after 2 or 3 months like later, when the incubation period is like very long. Coming to step number 6, that is observing and reviewing patient care. So when you have enough information about this cases, from where they are coming, the clinical symptoms and things like that, so you will observe and see who and what is generally driven, like from the line list, like what you can infer, like for providing some clinical information for the clinicians and others. So these observations are like very, very important. So you have to ask lot of questions to a lot of people, and you have to ask, do you always do it that way? Maybe they might have changed the practice of doing something, so that might have resulted in, they might be using a particular disinfectant solutions, and they might have changed it like immediately. That might be causing, that might be ineffective in disinfecting the skin or something, that might be causing. So you have to ask a lot of questions to a lot of people if you want to get like more information about the source and things like that. Have you seen other people to do it differently? What are the challenges with maintaining good techniques? What do you think which is causing outbreak? What procedures or medications might be missing because they are not in the chart or like not done infrequently? So you have to ask a lot of questions to observe the patient care and you to review, so that like you can contain the outbreak. So based on all this available information, you will generate the hypothesis, and you will use an analytical study to test the hypothesis. What is a hypothesis? You know very well, it is an educated guess about association between an exposure and an outcome. So there was an exposure, the outcome is a disease. So usually generated based on your descriptive data, that is line list and epidemic of what you have constructed and your spot maps and things like that. So comparing hypothesis with the established facts like laboratory evidence and clinical evidence, epidemiological evidence and environmental evidence will provide you vital information about that particular outbreak and your response measures of that outbreak. If you do not have the correct hypothesis, you will never get the right answer for that particular outbreak. So you have to get the right hypothesis by having adequate information in your descriptive data. So that will give you the information for doing further containment measures or preventive measures for preventing similar outbreaks in the future. So let us see an hypothesis generation of the Burkholderia cephasiae example, what we have seen. So here the hypothesis was the Burkholderia cephasiae was transmitted in 2 units, primarily in surgical intensive care unit in a hospital C, because the normal saline bottle contaminated with Burkholderia cephasiae and the same bottle used for dissolving the antibiotics powder for multiple patients undergoing treatment in the surgical intensive care unit. So you know very well, Burkholderia cephasiae usually that survives in fluids and things like that. So the IV fluid was contaminated, like whoever got IV fluid, that particular batch of IV fluid and the same big 500 ml bottle was used for multiple punctures, and it was used for diluting antibiotics and other medications. So that was the reason for this, because they were able to establish Burkholderia cephasiae from the IV fluids and the patient samples, and the genotypic mapping was also correlating with each other. So this is how you generate hypothesis based on the information what you get from your descriptive data analysis of your outbreak. So analytical study always, like outbreak investigations in healthcare facilities stop at descriptive epidemiology. Very rarely you go for an analytical study. The reason being, your hypothesis will give enough information about your preventive measures and like about controlling that particular outbreak and removing the source, etc., etc. But if you are not able to find that, then you may have to do an analytical study like a case control study or a cohort study. Usually cohort studies are not done because it is time consuming and resource intensive. Case control studies are done. It is again icing in the cake, but you should have the luxury of time and things like that. If you cannot find an answer, then you have to go for an analytical study based on the hypothesis what you have generated from the descriptive epidemiology. Coming to another important step in outbreak investigation regarding collecting and testing environmental samples. So this can be a powerful tool and definitive aspect of an outbreak investigation, but can also be expensive, misleading, and frustrating. So just you have to keep in mind, does a negative culture mean the bug was never there or just not there right now? Because see, the bug was there in that particular handrail, but maybe they might have done proper cleaning, then after that bug disappeared. This might be the reason for getting the patient getting infected with that particular bug. But again, you have to be very cautiously extrapolate this information regarding environmental sample results. So, and also you have to see, are we culturing the right things? So because environmental sample culturing will be decided by your descriptive epidemiological data, like what you get, and like the analysis of that particular data. So that will direct which samples to be culture, which samples to be sent for bacteriological culture, for identification and things like that. But if you just randomly do and randomly swab everything, you may not get anything, or you might get an information which might be very much misleading. So the methodologies for environmental sampling might be tricky and might not be the standard methods used for clinical lab. So many a times, you may have to neutralize the water samples and things like that, and you may have to pass it to special filters and things like that if you want to isolate microorganism which is very smaller in size, very well as microbiologists. So it is not that like unless you use the right methodology, you won't be able to isolate that pathogen from the environment. Some environmental pathogens have adapted to low nutrition environment and need special media to grow, which may not be available with you. And some sample results which result in overgrowth. That means the real pathogen will not get isolated because there is an overgrowth of other pathogens which is available in the environmental sample which you have collected. And even using the best methods, the yield can be still low because limited yield in getting the bacteria off the surface into the swab is a problem, and limited yield getting the bacteria off the swab into the media is also a very challenging procedure. As microbiologists, you know that very well. The suggestions which we would like to provide regarding environmental cultures, that environment is very big and swab is very small. So cultures, after you have to do culture after you have adequate information from the line list and observations. Talk with the lab about optimal methods first. Talk to your head of the department about like which method to use, like what media to use. Do we need any special selective media for this? Do we procure this filter papers, or do we have to refer the samples to a particular laboratory where they have expertise and things like that? Culture only things that are likely routes of transmission, like high touch surfaces, and don't keep swabbing everywhere. The cultures what makes sense for the organism, like Burkholderia, you know very well, it will be in fluids, water systems, and if it is a VRE, it will be in objects and surfaces. So based on like what organism you are dealing with from the clinical specimens, based on that you just go that should dictate your culturing practices. The ninth step is various possibilities based that there is an outbreak happening in your healthcare facility. So examples of control measures could include reinforcing hand hygiene in your health facility, establishing barrier between infected and colonized patients and non-infected and colonized patients, environmental controls like enhanced cleaning, reviewing disinfection of environment and equipments, removing suspected common sources like multi-dose medications, antisepsis, which is like, expired and things like that. Restrict antibiotic use to which organism is resistant, like Burkholderia cephacea is a typical example, because like it is intrinsically resistant to multiple antibiotics which are routinely used in your clinical practice. And sometimes you may have to close the unit for new admissions, like which might, until you evaluate and find a solution. Though this happens very rarely, but you may have to do that. There might not be any other option available with you. So follow up or definite investigation, like refine the case definition based on the initial findings and make it as focused as possible to detect the real cases. Continue surveillance efforts based on refined case definitions, and continue to review control measures regarding compliance, and do they need to be modified, like you have to check that. The final outbreak investigation step, which is often forgotten, is following up and communicating the results. So they do all the steps, but they forget to do communicating the results. So you have to communicate the findings of your investigation during the outbreak and also as the end of your outbreak investigation. So during the outbreak, you have to communicate the relevant information, what you are collecting and what your preliminary analysis results and things to your team members, your HACCs, and to the healthcare workers, like only the relevant information, not all the information regarding the outbreak. And you have to also educate your patients and attenders regarding general infection control measures like hand washing. If there is a potential spread of through particular mode of transmission, then you have to implement strict transmission based precautions and things like that. That has to be educated while the outbreak is ongoing. You need not tell about the outbreaks and like case detection, but infection prevention control measures has to be communicated to your staffs, like your sanitary workers, your patients and attenders, all during the outbreak also. So at the end of the outbreak investigation, you have to provide an oral briefing to your hospital superintendent, and you present to your this outbreak investigation findings to your hospital infection control committee meeting. And you should provide a report of which is in written to the public health officials, like if needed, and policymakers. That will happen through your medical superintendent of your hospital. You submit to your medical superintendent, and if he finds this is relevant for communicating to other hospitals and things like that, he will communicate to the public health authorities in your districts or in your mohalla or your state, like for further action, so that further similar outbreaks could be prevented in other health facilities. And you have to also educate the patients and attenders continuously about general infection prevention control measures and transmission based precautions, like if there is any specific things which has to be done. Conclusion: outbreaks are sentinel events that help us understand and confront emerging challenges in healthcare. They can play an important role in making recommendations that improve overall patient care and provide important opportunities for education. So nothing to be shameful when you get an outbreak. You should use that as an opportunity to improve your infection prevention control practices. So whenever you detect an outbreak, just if you find like that is relevant for investigating, just go ahead, investigate, and use this as an opportunity for strengthening your infection prevention control practices in your health facility, so that you can prevent such kind of outbreaks in the future. So for additional reading, there is a national guideline for infection prevention control and in healthcare facilities, which was released in March, actually January 2020. The updated version is from March 2020. And this is available from Ministry of Health and Family Welfare website. And there is a chapter in page number 152 about managing HAA outbreaks. And also there is a outbreak investigation module from National Centers for Disease Control. There is a PowerPoint presentation which you can use if you want to learn more about this outbreak. Regarding two outbreaks, like which All India Institute of Medical Sciences investigated, in one was in 2022 and another one is in 2019. The papers are here. You can the slides will be available with you, so you can use this outbreaks as a template, how they have gone ahead and investigated this outbreak. This is from Dr. Purva Mathur, who was leading this outbreak investigation. Like, we did support, but AIMS did the lead, and they conducted this outbreak investigation, which was published in Infection Control and Hospital Epidemiology Journal. So I would like to acknowledge Dr. Aarti Kapil, President IAMM, Sonal Saxena, Secretary, Dr. Purva Mathur from All India Institute of Medical Sciences, New Delhi, Dr. Lata Kapoor, National Centers for Disease Control, who is Additional Director heading the AMR and IPC program for the country, and all microbiology faculties and postgraduate residents for this providing me this opportunity and patient listening. And I would also like to thank my office colleagues, Dr. Daniel Vanderende, Dr. so much. If there are any questions, I'm happy to take.
Thank you, Dr. Balan. That was extremely knowledgeable and extremely, what should I say? It must have given the postgraduates all the desired information that they require, not only for exam, but also practical hands-on with, how to investigate, because this is something which they are going to see day in and day out when they land up in their job profile. So if there are any questions, we can take them. Somebody had raised their hand. You would like to ask. Somebody wanted to ask something. I've lost that person. That person is no longer connected. They had raised their hands. They wanted to ask something. So in case anybody has any question, please write them up in the chat box. Else, please raise your hand so that I can unmute you and you can ask Dr. Balan on your own. Dr. Balan, very often we see something which comes from the clinician side. The moment they realize that there is a increased number of reports related to one particular pathogen or something, they feel that come and swab everything. So I think that has been put to rest by your talk, and that creates a lot of confusion. But in your with all your experience, I would like to ask you as to how to convince actually the clinician that swabbing everything is not an answer for investigation of an outbreak. Because the older guidelines said that you go and swab all the environmental this thing. So that knowledge is still continuing.
Yeah, you are right, ma'am. Like, see, you are getting a bloodstream infection, for example. So just having it in environment, it won't enter into the blood, right? So there should be something which happened wrongly, and you have to find, like, through your outbreak investigation, you have to try to point out from how it would have entered into the blood. So it might be your hand hygiene practices, or it might be you are using some unsterile things, or you kept something there. So even for the pathogen from environment to enter into the blood, like, there should be something which is going wrong. Otherwise, it won't go inside. So what you have to, if you start doing a systematic outbreak investigation and try to give feedback to the clinician, this was the outbreak, this is what has happened, swabbing doesn't help, because, like, the source and mode of transmission was something different, not from the environment. Because from there to get into the blood, it needs something extra, right? Like,
Right.
it doesn't directly jump from there to go inside the blood most of the time. Even in this Burkholderia example which I was mentioning, so how the water pipes which were having, like, in one of the outbreaks, so what happened was, like, the water pipes had all this Burkholderia cephalaceae biofilm formation. So the medication
We've lost you, Dr. Balan. We can't hear you. Dr. Balan, we've lost your connection, I think.
with the sodium hypochlorite with high concentration, but nothing helped. But moving the medication trolley and putting a splash guard near the tray, so that completely stopped the further transmission of outbreak. And also definitely, the nurses and the ward staffs and the sanitary workers, everybody was educated about that and following hand hygiene and wearing gloves, and everything was like, practiced very correctly in that particular facility. But moving that, many a times, like if you don't understand how it is entering into the body, like how it can go inside the body and cause sepsis. So when you start investigating and when you produce more evidence and provide to the clinicians, they will accept. Because like this part of epidemiology is not properly taught to the clinicians in the medical colleges. Maybe we may have to emphasize more when they are thought about community outbreaks regarding this hospital epidemiology and healthcare associated outbreak chapters also has to be introduced in the curriculum. Look, that might bring in a behavior change in the young generation. But when you systematically investigate and provide more and more evidences and provide feedback to the clinicians, one day the behavior change will happen and they will not be asking for swabbing everything, which might be misleading or provide inconclusive evidence.
Okay. Thank you. I think, Aarti ma'am, would you like to say something? I think with that, we will conclude this. Ma'am, you're muted. Ma'am, you're muted.
All right. So in the end, thank you so much, Dr. Wallen. I want to again emphasize one thing for the residents, that please don't think that these steps that Dr. Wallen also said, it's not one after the other necessarily. As soon as you have a suspicion, must immediately implement standard precautions, and whatever based on your initial hypothesis, intervene. But as much as you can conclude, like he said, if you have the luxury of time, or if you're not able to control with the first line of standard precautions, then continue with whatever next step. But please make sure that you immediately intervene even at the suspicion of an outbreak. And thank you once again. Thank you, Dr. Sonal, for keeping it up all the time consistently. I'm sure our residents will be benefited. Thank you.
Okay. Thank you. So this will be available on our YouTube channel, although it was streamed live also. But any of you who missed it can go on our YouTube channel and see it again. And in May, we'll be talking about DST in Mycobacterium tuberculosis by Dr. Camilla, an extremely renowned person in TB. So see you again on the third Friday. And thank you, Dr. Wallen. I know you were traveling. It was difficult for you. But thank you so much for taking out time and enlightening all our postgraduates as well as the microbiologists all across. And we are having very good comments in the comment box also. Everybody is quite happy with this. There is one more example which people have given where antibiotic vial was the source of the cold area outbreak in Mumbai, TN Nair Hospital. So recommend all the residents to read this thing. Okay. Thank you. With that, we wind up. Thank you again, Dr. Wallen.
Thank you. Bye.
Bye, and see you all in May.